So there was a question that patient was Parkinsonism disease, okay? And she was on ropinirole. You know our ropinirole, right? This is our non-ergot derivative, right? This is our non-ergot derivative dopamine agonist, right? So she's on ropinirole. Now the patient started to have visual hallucination. What should you do? Will you go for rivastigmine? Because as you know, Parkinsonism, visual hallucination, maybe this one, you will think that maybe this is the visual hallucination with Parkinson's, maybe this is Lewy body syndrome. No, dear. As long as there is no dementia, there is no dementia. They didn't mention about any dementia, no dementia. And they mentioned about this ropinirole. After using that ropinirole, it has started. So it is not because of the Lewy body syndrome. It is because of this ropinirole. So your treatment should not be rivastigmine. Your treatment should be stop the ropinirole or reduce, whatever in your option. Okay. In our option, there was actually reduce. It was there. So reduce ropinirole. Got my point? So this is about Parkinsonism with ropinirole with visual hallucination. So if Parkinsonism disease with hallucination, with dementia, these three, okay, this is Lewy body. This is Lewy body. That time, yes, you will go as the treatment of Alzheimer. You can go with rivastigmine. It is okay. Got my point? Another thing is that if Parkinson's disease, there is no hallucination, no dementia, they're telling that patient is having psychotic-like psychosis. What should be the treatment? Treatment should be quetiapine or clozapine. If both are there, your preferable is quetiapine. So this is about Parkinsonism associated with some psychiatrical problem. Okay. So now come with, there is a question that patient is Parkinson's disease and he is on L-DOPA, okay? He's on L-DOPA. Now patient is having dyskinetic-like feature, dyskinesia more. So this is actually L-DOPA dyskinesia. This is what? L-DOPA induced dyskinesia. So what should be your treatment? As L-DOPA is causing this dyskinesia, treatment should be reduce it. Reduce L-DOPA. You got my point? Reduce L-DOPA. So this is L-DOPA induced dyskinesia. Okay. Now, so here, what was our treatment? Our treatment was reduce it. Reduced L-DOPA. Not L-PA, of course, L-DOPA. I think you will get it. Because when I'm talking at a time writing, there is a chance of a spelling mistake. It is obvious. Mistake will be there. Okay, but I think when you are listening to my lecture, so it's okay even there is any spelling mistake. You will get it. Okay. Okay. So now the another important thing is that this one actually reduce L-DOPA means this specific question. It was like that the patient was with synecate. So patient was with synecate. They are having this dyskinesia. What you should do? So you will reduce the synecate. Same synecate is the dopamine combination, right? So reduce that synecate. This is the one. Okay. Now, one more thing I want to tell you, that is about the on and off syndrome. This is about the on and off syndrome. This is so important. On and off syndrome. If you see in between, there is like off syndrome in or even after using L-DOPA, somebody is even after using L-DOPA, they are having like off syndrome. Okay, off syndrome means what? There will be like what it is telling. I mean, like bradykinesia, like rigidity, like freezing, like off. Their body is off, switch off. their body is switching off, freezing, bradykinesia, rigid, having. So these are known as off syndrome. Okay, so if like this off symptoms are there, if off symptoms are there and they are already on levodopa, then you have to increase the dose of the levodopa. If a starting dose is not enough, you can dose up to 600 mg. You got my point? So you can increase the dose of levodopa. So here what happened? Actually increase dose. Number one. Number two, if you see